Thank you very much for joining us for this roundtable discussion on fatigue in prostate cancer patients. I'm Phil Cornford, and this session has been sponsored by Bayer. There's going to be relatively little talking from me, but I have got one or two just introductory slides that we will go through just to begin with. And in particular, so what is fatigue? Fatigue is not just, I feel a bit tired. Fatigue is excessive tiredness and lack of energy that doesn't get better after rest or sleep. And it's different from you went for a run and feel tired. It's different from I've overdone it. Cancer-related fatigue negatively impacts people's quality of life. It might be disease-related, it might be treatment-related, and chronic illnesses can be associated with age. So all of these things might be a factor for people with prostate cancer. If you want to understand, so how would you judge whether a patient had fatigue? Or if you're a patient and you're thinking, does this apply to me? Then the question is, have I been spending more time in bed or sleeping more? What about quality of sleep? Do I find it difficult to concentrate? Do I find it hard to think clearly or make decisions? And all of that we would classify as mental fatigue. These are the sort of questions you might ask if we're thinking about physical fatigue. And that can be combined with emotional fatigue. Lack of interest or motivation in daily life, feeling sad or depressed. And if you're really tired and you have fatigue as part of your disease, then this can be an addition to it. All of these things, some of them mental, some of them physical, are both related to fatigue and can be ways in which you can notice there's a problem. Because this is very much a patient-led session, I have some data here that was collected in the UK by Prostate Cancer Research. And they had a survey. You can see here the range of different stages of disease of the patients who answered the survey. And these were all the things they said about what does it mean to live well with prostate cancer. As we think about survivorship and how we can improve the quality of life, these are the things that are important to the patients who answered that survey. And you can see that an active life, treatment side effects and quality of life all are really important. So what sort of effect did fatigue have for these? This study wasn't just about fatigue, but it was included. But you can see here that fatigue was having a significant impact on patients with prostate cancer and on their ability to cope with general activities in life. It has a bigger impact on their enjoyment of life than cognitive impairment, and twice as many people said it completely interfered with their life. 1 in 4 people saying that they had issues with fatigue. Now, these were the things they said about how it affected their life. The things that they needed to do, the way they felt about it. And you can see there's a theme here. Weakness, lack of enthusiasm, having a big impact, affecting everyday activities, affecting their sleep pattern. So this, from a clinician's point of view, is always interesting. So most patients did talk to their team about fatigue. Well, there's still nearly a third who just forgot to mention it. And when you look at what effect it's having on their life from those previous studies, you can see this is having a major effect. Worse than that, lots of them found that they didn't have any idea what to do about it. There are things that they have suggested here. You can see exercise appears quite a lot. But it's not always clear for patients or for healthcare workers what to do about it. And it's that we're going to try and pick apart over the next 50 minutes or so. This study also said how much it interferes. You can see that 30% of people said that it interfered with their daily activity, and only 5% of people or less said it didn't interfere. These are some things that have been tried and discussed and may be discussed later as we talk through what's possible. And these are some websites that you might consider looking at for more information. So, as part of this, it is possible for you to vote. And a little bit, I'm interested to understand who's in the room. So, in a minute, I'm going to show a QR code. And if you've got a phone with you, you'll be able to vote and tell us what's going on. So there'll be there's a voting session now to understand who's here and to make sure that you understand it works, and then a voting session at the end to see what you learnt from this. So this is the first question. So, are you A, a nurse, B, a patient, C, a patient advocate, a physician, or someone else? And we should be able to start voting now. There we are. Oh, I wonder who others are. That'll be interesting. There's quite a few others. Right. Thank you very much. So this session is largely going to be a conversation. You said trying to get rid of... I haven't pressed close voting, that's why. So I can't escape. Right. I'm going to put this bit up. So, across the front here, we have a range of different individuals, okay? And it might... Well, have you got two? That's cheeky, all right. I'll use this one then. So we have a range of different people. I don't intend to do very much of the talking here. I'm mainly here to chair. And these people in front of you are going to talk to you. They all have different roles. And it might be just very good to start with for everybody just to introduce themselves and to say exactly who you are and why we asked you to be here, because it's quite apparent that there are different roles. There is also roving mites. We're a reasonably small group, and I'm more than happy to take questions from the floor. If people want to ask something, or of any particular individual, if you come to a mic, I'll just ask you to say your name, and we'll say which mic number, and then we can talk. Then you can ask questions of the panel. So perhaps, Richard, you'd like to explain exactly who you are to begin with.
Greetings all. I am Richard Wassersug. I am a prostate cancer patient and prostate cancer researcher from Vancouver, Canada.
Hi, hello. My name's Val Curry. I'm the wife of a cancer patient, and I've just been asked to give a little bit of an insight into what may get missed when we visit the consultants. Perhaps, my husband's not willing to mention, but I'm very happy to say. Okay, thank you.
John Dowling, a 20-year prostate cancer survivor, and I'm supposedly here as a patient advocate. There you are.
Inge van Oort, oncological urologist. I'm here as a doctor who sees, I think, 80% of prostate cancer patients with mostly metastasized prostate cancer.
Hi, I'm Louisa. I'm a clinical nurse specialist. I work in London in the UK, and I look after men with prostate cancer.
Thank you very much. So, Richard, can you share your personal experience to what it's like to be on ADT and how fatigue has affected you and what you've done about it?
Thank you. So I come here wearing two hats. I've been a prostate cancer patient for almost 25 years, and as with most cancer patients, I have suffered at various times from fatigue. My interest in fatigue is not just simply because I have suffered from it and from it associated with prostate cancer. It's also a research topic for me, and that's because I was a research scientist before I got prostate cancer. As such, it was not surprising that fatigue and other prostate cancer treatment side effects caught my interest. By way of background, I had a prostatectomy. It failed. My PSA started climbing. I had salvage radiotherapy. It failed. My PSA started climbing again. And I've been on ADT as a consequence. And that started over 20 years ago. And I've been rather continuously on ADT for over 20 years. Fatigue is a common problem for a lot of cancer patients and can be provoked by a lot of treatments. It is often part of a trio that also includes insomnia and depression. Fatigue, insomnia, and depression can feedback on each other. Anxiety about whether the cancer treatments are successful can, for example, disrupt sleep, leading to poor sleep quality and subsequent daytime fatigue. Fatigue itself can lead to depression. Antidepressive medications may help with the insomnia, but some of them can exacerbate fatigue, and so it goes. By far, ADT produces the most protracted fatigue that other patients experience or report experience, and so do I. And I felt it in a variety of ways. I did not sleep well on Leukeran. We call it Lupron in North America, the standard ADT medication that I started on. That led to daytime physical fatigue. And I experienced what is not common, which is not well defined, but was mentioned in the introduction, the mental fatigue as well, or brain fog. As a professor, I could still do research and teach, but I found myself spatially challenged. That showed up in losing my car in a large parking lot and having trouble finding papers in the mess of papers on my desk. Simple computer spatial puzzles, which I often played at the end of the day for a diversion, before I was on ADT, became impossible to solve when I was on ADT. I wasn't an athlete nor advised to exercise when I started on ADT, but on Leukeran, I lost muscle mass, gained weight as fat, and became mildly anemic. Those are standard side effects of ADT. Collectively, they can present as increased difficulty walking up a few flights of stairs or simply getting off the couch. And as I said, I wasn't sleeping well. So I had pretty severe fatigue, both of a mental and physical nature. As a scientist, I was interested in how much of that fatigue was a direct effect of the androgen deprivation versus a negative placebo effect. As such, I began to do some research with a graduate student where we castrated male rats to make them androgen deprived, then looked at their sleep cycles and activity patterns. We even measured their brain activity to look at the quality of their sleep, not just the quantity, but the quality. Androgen deprivation via surgical castration did indeed alter brain wave patterns during sleep for the rats, and they showed reduced activity during their normal activity time of the day. Earlier this year, the same student, who's now a lecturer at Otago University in New Zealand, and I co-authored a paper with colleagues in London, England, showing that drugs like Leukeron do indeed alter sleep patterns in prostate cancer patients. But then, what can one do about it? We already know that physical activity is the best way of handling fatigue from ADT. Studies show that exercise helps with not just physical fatigue, but also with the mental fatigue. However, we also know that most prostate cancer patients are not getting enough exercise. Few patients enter exercise research studies, and we know that the beneficial effects of exercise are not necessarily sustained after those research studies are over. Against that background, I want to apologize for reading this. I didn't know, by the way, as an aside, when I was going to get in through the airports, so I wrote it all out in the last 2 days. I don't normally read my lectures. All right. Against that background, I want to mention a couple of programs that I know of where cancer patients began exercising within a research program setting and stayed with a regular exercise long after the research ended. The first one is it's called A Breast in a Boat, one word, A Breast in a Boat, program for breast cancer patients. That began as a research study some 25 years ago in my hometown of Vancouver. The researchers thought that paddling dragon boats might help women with lymphedema, the swelling of their arms after breast surgery. So to investigate that, he formed a dragon boat team with breast cancer patients to test out his idea. Interestingly, the paddling did not particularly improve the lymphedema. However, the women formed such strong social bonds that they decided to stay together as a dragon boat team, and they proliferated. There are now 290 breast cancer dragon boat teams around the world distributed in 35 different countries. Another example are prostate cancer football teams in Denmark. They too started as a researcher investigating the benefits of team sports for prostate cancer patients, specifically on ADT. There now are prostate cancer football teams that practice together throughout much of Denmark, even though the research program is long over. Following the model of the original A Breast in a Boat dragon boat team in Vancouver, 6 years ago, my friends and I put together a prostate cancer dragon boat. So they were called A Breast in a Boat. We are butts in a boat. What is so impressive to me, although these are really only case studies, is that both the Danish football teams and the dragon boat cancer teams have proven themselves to be sustainable outside of any research studies. All of these programs, even when team practices were not possible during COVID, continued nevertheless. Our dragon boat team, for example, met in a park on land where we could safely both exercise physically and socialize with safe distance during COVID. And a similar thing happened in Denmark with their football teams. What is common to these team exercise programs is that the individuals do not compete one-on-one against each other. In the case of the football teams, they have practices that teams are balanced in terms of ability, so they're not really directly one-on-one aggressively competing. Yet the teams do compete, but they compete as teams against other teams. Exercising intensely together gives a context for socializing afterwards. We go out for beer after dragon boat practice. The social bonds that are formed then inspire participants to continue to exercise together. And in a reciprocal fashion, the exercising gives a rationale for socializing, and the socializing builds a commitment to one's fellow team members to show up for the next practice. I believe we need to encourage more such team activities for prostate cancer patients. As such, I'd be happy to talk to anyone here or anywhere about how they might build team exercise programs in their community. After all, our Butts in a Boat team is always looking for other prostate cancer teams to compete against. Thank you very much for giving me a chance to tell this story.
So thank you very much. One thing comes to mind. So in the UK, NICE has recommended that you do resistance exercise, and paddling a boat would definitely count as resistance exercise, so that's perfect.
For dragon boating is both. I usually bellow anyway. Dragon boating is both, it's resistance exercise for sure, it's sprints. But the worst event is a 2-kilometer, 10-minute race. I can't handle that. We do 100, 200, or 500-meter races, and it's intensely aerobic and intense resistance training for the upper body particularly.
So yeah, so I completely agree. So I am involved in recruiting for Stamina, which is a UK trial where people go to the gym, and I really wonder whether it will have the same social bit that the dragon boat racing has. And I wondered your views on how important the social bit was.
It's absolutely essential. But I'd also say there's something about dragon boating as an example is you're next to a person and you have to match your paddle with theirs or the person in front of ahead of you. It can't, if you're bigger or stronger and you're going to say, I could beat that guy, it's not going to help you or the team or them. So it requires working really hard to collaborate, and that instantly builds something of a social bond. So after you've come off the boat sweating, you say, hey, let's go for a beer. And the socialization comes out of the exercise. And then when you socialize, you know the person, you feel responsible to come back. So there's a very important part, which I'm not sure now. I look forward to perhaps we'll have a paper on this, and you're comparing what can or can't be done to build exercise in the gym. And there are ways of doing pair exercises, boxing, pretending to box, or whatever, where you match face-to-face doing the same. I found that we could do that in a gym. We'd all be trying to do squats at the same time. So you can build, you don't have to be in a boat, but you can, I think, in a stamina setting. And I think those are subtle but really important variables, is to push together to them to see if they can match. And that builds bonds and gives you the social context.
I suspect they get quite a lot of competition because they compete with each other's scores. So that's true. But I wonder if it's got the same social element. I will be really interested to see when we're done.
If you're building your program, I don't know the details, on competition, you're going to then have a huge number of guys who feel disabled because they're on ADT and won't even join the program. And that's the difference. That's why I think the group programs are so important.
Yeah. Val, can you tell us a little bit about what fatigue means and what you notice as a carer?
Okay, so to begin with, the question that was given to me to respond to was, what can carers tell us about patient experience that might get missed? And I have to say, I really didn't quite know from which direction to approach that question. And I had it all written down and neatly typed up what I was going to say until about midnight last night. And I suddenly thought, do you know what, I think I've got this wrong. So now I've got a whole lot of scribbled notes. So apologies if I seem to be turning pages. I'll try not to. And also, my experience, and I can only speak about my experience, obviously, and my husband's experience, is that the great care that we have been shown from the consultants at Guy's and St Thomas's in London has been fantastic. And they have been very good at making sure that they get all the information that they feel is necessary, and just general information. So there's not a lot, I don't think, that I can add in many ways. However, firstly, let me say that Mrs. Sympathy is not my name, okay? So when Andy was diagnosed with having advanced prostate cancer, that had to change. I mean, my daughters will be the first people to say to you, you know, I remember when my youngest daughter was about 8, saying to my eldest daughter, you know, oh, Mum didn't give me much sympathy. And my eldest daughter, Jessica, said, well, what did you expect? So poor Andy was sort of very definitely on the losing side there to begin with. However, obviously that had to change. And also I'm not a great patient person either. I don't have a lot of patience, and that has had to change. Anyway, Andy was diagnosed with advanced prostate cancer in May. To add to his stress already, because that came as a bit of a surprise to us, we also had our daughter's wedding just 3 weeks later. And so we had the additional stress of deciding whether or not to tell her about the cancer before the wedding or whether to wait until afterwards. Rightly or wrongly, we decided to wait until afterwards. And then got it in the neck because we'd done that. But all of these social things that happen in your life also add to stress. And if you're very stressed, you do get very fatigued. Andy certainly did. And I was also asked to mention things that he may have been unhappy to speak about in front of the consultants in case it affected his ability to have treatment. One of the things was, in fact, when he what started the ADT, he's also type 1 diabetic and has been for 50 years. And unfortunately, the hormones meant that his sugar levels rose. And then when he had chemotherapy and was having steroids, then of course his sugar levels went even higher. So that was really difficult for a while for him to calculate how much insulin he needed to take. And he did have concerns that maybe if it got out of hand, that might stop the treatment. But it didn't, thankfully. And then also the chemotherapy gave him lymphedema, which affected his ability to do much exercise, because for us exercise was walking. We really enjoy walking. We're very lucky where we live. We can walk for 2 to 3 hours in a local woods, even though we're in London. And we used to walk at a reasonable rate. That had to stop. We had to suddenly walk much, much slower and for less distance and with more frequent stops. So he was concerned that perhaps because of the weight and not being able to exercise as much, it may be that he would have to stop treatment. Thankfully, as I say, he didn't. So, yes, there is definitely physical fatigue, but there is an awful lot of mental fatigue when you have advanced prostate cancer and you have chemotherapy and you have radiotherapy. And for me, as a carer, the difficulty was getting that balance between being a nagging wife, which he's obviously quite used to, but also cajoling him into doing more exercise when he really wasn't feeling like doing so. But we did, and I'm sure that that made a very big difference to his lymphedema. But there are lots of ways of reducing mental fatigue, and not just physical exercise. But again, at Guy's, there is a fantastic advanced prostate cancer club which run many, many different classes. And originally, before COVID, they were in person. They all then went online, which was fantastic, because it meant that the group could stay together and could still support each other. And some of the things that they run are the walking group, there's yoga, there's breathing exercises, there's relaxation, there's mindful classes, and art classes. And of course, when we get together for the walking group, there is a lot of camaraderie for both the patients and for the carers, so we can discuss, the issues as carers. So in general, I would say we have been extremely lucky to have had guys. We've had guys to support Andy throughout his cancer treatment. He's finished his last his last Prostrap injection. That will take him through till September, when I'm assuming the effects of that will start to reduce. So we will see then. I'm really quite keen to see then whether or not his stress levels, his anxiety levels improve, and therefore his frustrations with life in general improve. Thank you.
Thank you very much. Now, John, I know that you are both a patient, but you've been very involved with EAU22, and they collected a lot of interesting data on what it was like for patients. Perhaps a little bit from your own experience and some data from EAU22.
Well, I think the principal point that we might take from the EAU22 surveys is that the level of fatigue related really to the kind of treatment that the patient was on. I suppose it would be of no great surprise to learn that those on chemotherapy suffered the greatest extent of fatigue. With regard to others, the combination of radiotherapy and ADT seemed to be the next highest category. And of course, ADT itself is a widespread fatigue initiator. And it does affect different people in different ways. If I might just relate, just from a personal point of view, I can remember being initially on ADT and seemed to be sailing through until month 4, and suddenly, in the midst of a 2-day training workshop that I was giving in a hospital of all places, my legs just gave way. They turned to jelly. And that was embarrassing enough, trying to cope and continue through the planned session. But in effect, I had to change my way of earning a living because I just could not cope at that point with the fatigue of doing training courses, which tend to be somewhat telling. Sugar. Sorry about that. I don't know whether it's telling me to shut up or not. In terms of that scenario, it took me some time to recover and to build up stamina again through exercise. One of the mistakes I probably made at that point was trying to do most of the exercise rebuilding on my own. One of the things that I was struck when I saw Richard's group in Vancouver was that collegiality and comradeship that develops with his Dragon Boat crew. And I think that's a key not only to helping people to rebuild their stamina on an individual level, but from an organizational point of view with prostate cancer support groups, it's important that they have developments such as teams of various kinds, the football, the dragon boats, and so on. So I'm fascinated by the progress that he's made. In terms of the ordinary patient, I would hope that patient and patient organizations can get a ready reception for a more holistic approach, that there's mental and physical fatigue, that they're often intertwined. There's a whole plethora of approaches, and all I would say is that I found that you can't do it on your own. So I joined a hill walking club, and my stamina levels improved no end, much better than walking solo.
Thank you very much. So we've heard a lot about what the trouble is, and now for the second half of the session, we're going to talk a little bit about what the solutions are. Okay, so Inga, perhaps you could talk us through what you see and what we can do about it.
Well, I've been treating prostate cancer patients for a long time now. In the beginning, it was clear. Well, they told me, you have patients, they get on hormones, they get tired, that's it. There was nothing to talk about. They get tired, nothing to do about it. Okay. Luckily, that changed in the last years, and I saw that even asking about the fatigue, but because a lot of my colleagues will not ask because you cannot do anything about it, but asking and trying to motivate them to get starting doing something like sports, that would change their attitude, that would change their fatigue. But that is most of the time not the answer they want to hear, because they say, okay, doctor, can I do anything about my disease? And I say, yeah, you can. And they're like, okay, what is it? You can start moving, start exercising. And they were like, okay, that's not the answer I want to hear. And then most of the time there is caregiver, and most of the time an older daughter next to that, and they say, you see, you have to start moving. Move your butt, and start doing sports. I told them. It's like that. So it's. I always say then, don't be the nagging wife, but try to start doing sports or exercise together. And it's not like you have to get and do a marathon. You don't have to do hours of sports in the gym, because most of the men don't like the gym. But things like, well, if you cannot walk that far, just 5 minutes. Every day, 5 minutes, that's a start. And that is really good. So I would be asking my patient, how are you doing? Is it 5 minutes? It's even 10. And when I started asking more, I would get more response like, oh, I've been doing 10,000 steps a day. Now it's 15,000 steps a day. And my assumption in the beginning of when you get hormones, you gain weight and get fatigue. If you really do ask them and see that they're changing because they do exercise, they even lose a lot of weight. I've seen a lot of my patients get really, really, really fit beforehand, before even the hormones. They didn't do that, or they didn't do anything on sports. And now they see that if you do sports, your fatigue, your mental fatigue will also, well, diminish. It's they are different than beforehand, but they see that what they can do something about it. And that is really good to see, and it's really good to see. And even better if you see a couple starting walking together, because it's also you see the bonding and not the two people sitting next to each other and having not a really good time, because a lot changed while getting ADT. But if they walk together or do something together, or bike in Holland, of course, biking, a lot of biking, that you see that they enjoy it and that they have a story to tell, and it's so much fun. It really is fun to ask them about their what they did and how much fun and they enjoy it. So now I have to convince my colleagues to start to talk more about fatigue. I have a lot of good nurse specialists, and they're really good also at motivating, telling them what kind of programs there are. We don't have dragon boats, but that may be the next thing. I think doing it in a club or with as a couple, or you cannot do it and start it on your own. If you're already tired and you start, then you're like, okay, this is not fun. But if you do it together or with a group, then you see that there will be more fun, and that it's not something you have to do. It's something you can do, and you enjoy life more. It's all about quality of life.
And I think that's really important for physicians. The positive impact that you can have just by asking about it is very understood. We tend to ask about the side effects of the drugs and possible complications.
And only
of
talk
the
about
disease.
PSA and
Yeah,
just
and the
be
PSA
only
stuff.
the medical part, but it's more than that. It's
And
so much more.
If you can mention the other things, then you open up a conversation that begins to be really powerful to improve people's quality of life. And it's a bit interesting because even in the PCR study, a third of people just never mentioned it. They never told anybody. And when you listen to the patients about exactly what it's like, both the mental fatigue, so if you feel a bit fogged, if you have no drive, then of course the answer is you don't mention things when you come to clinic.
Can I just comment? It's also possible that the 1/3 that didn't mention it is the 1/3 that's exercising already.
It is, but they appear to still have significant levels of fatigue. So, yeah. Right. Louisa's got a little presentation for us with some practical tips about exactly what we can do.
So, sorry to be so formal. I'm not formal. I'm just a woman and I'm 54. And prostate cancer isn't the only reason you get mental fog and fatigue. So this is my little aide memoir. So I'm very much speaking from the nurse perspective here, and hopefully just giving an overview of some of the things that we think about when we're talking to men and their loved ones about their side effects, but particularly about fatigue. So I'll start off with saying that probably one of the most important things that I've learned over the years is the skill of not doing anything, of listening. Because I think as health professionals, we want to go in and we want to fix things. It's what we're here for. And that the confidence to just sit back and say, how are you doing? You know, what's going on for you is really, really important. Because if you don't listen, you don't know, and assumptions are never good. So what I really want to hear about, if I'm talking to somebody, is how are they? And if they do have fatigue, what does that mean for you? And I think Richard described it and Val described it really well. It means lots of things for different people. And what the fatigue means to the person, and what are they talking about when they say fatigue, and most importantly, or equally importantly, what's the impact of it? What does it mean to you? What's it stopping you doing? What's it, you know, what's the importance of this fatigue in your life is really, really useful. And I also quite like to know, what have you tried? Because there's no point me waxing lyrical about all my great ideas if you've already tried it. So I think that initial time of just sitting and chatting and getting to find out what the problem is really, really important and a good place to start. So this just gives me an idea. So if I'm talking about fatigue to someone, in the back of my mind, I've probably got a lot of things that I might think is almost like a little toolbox of things that I can bring out as ideas. And that's why, you know, what have you tried is really important, and what does it mean to you is really important. You know, and there's some things that maybe aren't that evidence-based, but certainly things that people have found really useful. Things like complementary therapies, as Phil said earlier. Sleep hygiene is a really unrelated thing. Lots of people struggle with sleep. And sometimes it can be things like hot flushes or getting up for the loo. But sometimes it's all about our sleep routine. And where I work, one of our complementary therapists does an amazing course on how to improve your sleep. And I certainly learned a lot from it when I went to it with patients and then realised that I needed it myself. But things like, you know, alcohol's not your friend if you're fatigued, because it really affects your energy levels and it affects your sleep. Eating well is really important. Fatigue diaries I'm a big fan of, because if fatigue is really impacting on your life, then keeping a diary of when you feel particularly tired is really helpful, because A, it can help you pace what you do. We talk about plan, prioritise and pace, and that means if you know that you have dips in the afternoon, then maybe plan a rest for the afternoon. But if you've got all your energy in the morning, then maybe get your exercise in then. And you know, if you've got 10 things to do, finding out what the most important thing for you to do is, and that might be seeing your family rather than working, then maybe think about what you want to prioritise for that day. And that's all about quality of life, to make sure that the energy you've got is spent doing the things that are important. And you can see there's other things, but you know, getting support from other people is the other big thing. I think sometimes, and I think Val summed it up really well, you know, sometimes people can be reticent to talk about what's bothering them. And, you know, making sure that you do talk to the people around you and let them know how you're feeling helps them help you to prioritise, pace and plan as well. But you can see at the top, I've highlighted exercise, because as we've said over and over again, exercise is where we've got really good evidence that we can help fatigue. And there's lots of ways we can use our kind of skills to try and help people reach the goals that they want to get to. But I think what I'd also say is this, you know, it's a busy slide and there's lots of things, but it's really hard to do all these things when you're tired. And you've got that kind of circle of, yeah, I know I need to do this, but do you know what? I'm absolutely exhausted and I don't want to do it. Yes, I know I should be exercising, but I feel really down and my motivation is in the boots and I don't want to do it. So you've got that kind of self-fulfilling prophecy a little bit. I'm tired, so therefore these wonderful strategies seem a little bit out of reach. And I think this is something I'm really keen on. So is the idea is, I think as health professionals, we spend a lot of time telling people what they should do. We give you information, we write books, we write leaflets, we send you to websites, we tell you what you should be doing. But sometimes knowledge isn't enough, because in the ideal world, you get information, you have a strategy, and then you you do it, action happens. But actually in the real world, for all of us, I know how to lose weight. I'm not Kate Moss. You know, it's because I don't have the motivation to do what I need to do. And for lots of us, having the information isn't enough. And that's particularly true with fatigue. And there's something in the middle here, it's called self-efficacy, and it's about your belief in your ability to perform something. And that's what we need to work on, because we can give people all the advice in the world, but if they don't have that perceived, what we call self-efficacy, then it's not going to translate into action. And again, there's a lot of work on this, but this is what I kind of have in my head a lot of the time. So self-efficacy is really a judgment on how likely you are to be able to do it, and it's how you feel, and it's about what you choose to do, how much effort you've got to put into it, and what you do when things go wrong. And for me, there's 4 things that really help with this. Doing something is really good. So if you can actually practically show someone what to do, it's much better than showing them a video or just telling them. Seeing other people do something, and that has to be people similar to you. So in Richard's talk, he said about the dragon boat and the exercise classes. That's people in the same boat as you succeeding, and that's really important. And then being influenced that you can achieve a goal, and that's kind of our job as well. You know, you can do this. I know you can. This is how you can get there. And then getting feedback. And I think, again, what Inga said, you know, how's your walking? How many steps have you done? Getting feedback about how well you're doing is really important. And for us, it's really important, and this is a model that I really like, and I know Richard's really keen on, motivational interviewing. And I like this because it's about partnership, it's collaboration. It's about, I might know bits and pieces about prostate cancer and about exercise, but you are the expert in you. And only you know what your motivations and your goals and your expectations are. And the idea is that we use this approach to empathise, to make sure that we're with you. Developing discrepancies is really interesting. It's about helping us all to realise that what we want and what we're doing aren't necessarily working well together. And sometimes we just need to know that in order to sort of move forward. Rolling resistance is really hard for health professionals. So accepting that, no, I don't want to do that, and stepping back and saying, okay, that's where you are at the moment is quite difficult. But we often do what we call look for change talk. And change talk is when I or you say something that shows a desire or an ability or a need or a reason to make a change. And if you can get people to start talking about that, why do you want to make change, what's important to you, you can use that as a springboard. And then, as I said, self-efficacy. So drawing all that together, if you've got all those things, we know what we need to do. These are some of the things. So as health professionals, listen, stop telling and start listening. Think about what your patient's priorities are, and if you're a patient, tell us what your priorities are, and look for and build on that change talk. I love goals. I'm a big planner. I've got a list for everything, and action planning is really interesting because it's about accountability. You set yourself a plan. It's almost like a contract with yourself, and it's really good to do that, and you can come back to it. And then build on small steps. It's pointless trying to make a plan that's unachievable. And then practical help, you know, if you're a health professional, use your teams like trainers and physios, etc. Trying's better than being told. And I'm a massive fan of peer support, as Val knows. I think anything that brings people together, support group, classes, etc., is about motivation for the group, as Richard really eloquently said. The group motivates you and you motivate the group. And you're much more likely to do something if you do it with someone else because, again, it's a mutual contract. So that's my whistle-stop tour, and again, I'm sorry for the formality of the slides, but yeah, pray God.
But thank you really much, because I think that gives us some take-home things that we can do that are different, and and ideas of different ways of thinking about it. If there are people who want to comment, I'm more than happy to take comments from the microphones. I can see someone moving to the microphone. Microphone 4.
Hello, Henry Lazarovich from Liverpool. A question to Richard, and I guess to the panel as well. The boat thing you talked about there was very interesting, because extrapolating chronic or fatigue from just prostate cancer into the broader sphere of everybody, and by this I'm including CFS and long COVID as well, there's been recent evidence or change in practice in terms of CFS and long COVID where exercise has been sort of de-emphasised because of the boom and bust cycle which patients get into. And I guess if you're someone who's previously been fit and well and running around doing X, Y, and Z, and then you go and try and do this straight off, you're going to hit this boom bust cycle all the time. And so pacing comes into it very much more, as you've alluded to there. And I'm just wondering whether this boat scenario is actually an innate way that you're building in pacing. So they're getting the exercise, but the pacing's there, and rather like hill walking, because actually the pace you take is the pace of the slowest person there.
Thank you. That's a very good question. There's some unique things about dragon boating, in the sense that, and particularly if you are a population which has some disability. I mean, and we are, and we're not, by the way, in Vancouver, the only health-related exercise dragon boating team. There's the Eye of the Dragon, which is a blind team. So their partners set the pace next to them. They can get the sense for the feel of what their partner's doing, even though they can't see. There's an MS team. There's a breast cancer team. Within the context of the EAU, there is a letter O, numeral 2P, O2P. This is the people who are on dialysis. They have a team. So there have to be considerations. As the MS team, they have a lift to get people in and out of the boat if they're wheelchair dependent. But at the same time, the teams have to understand that they can't be pushed faster than the weakest member of the team. So there's some ways of standardizing that. The people at the front of the boat set the pace. Since we're all Dragon Boat members who are also prostate cancer patients, we don't necessarily put the guys who are 50 years old on active surveillance at the front and the people who are metastatic and have severe lymphedema, whatever, at the back. We have to be aware of the limitations. But that's allowed. And the thing about it is it's astonishing because then you can build a community with people who don't have to be actually exactly the same as you. I mean, often we build friends who have the same interests or same ability. But this model forces collegiality and absolute collaborativeness. It's a sport that only works because it's egalitarian, not because there's individual one-on-one dominance. And that is a big problem because amongst males who are trying to present, this is a little bit metaphorical, men who are trying to preserve what masculinity they have when they're castrated, they don't want to necessarily go out and be beat up by somebody else in some competitive setting. So I see a uniqueness about it, and I see that this has to be real challenges. And I'm looking across here to build the commonality that can lead to a marriage co-support, an exercise program, does take a sensitivity, but I would say you have to put almost as much effort into understanding the building of the community of co-support in order to get the exercise program to become so dominant.
What I also think is that the word exercise is always the one thing that starts them thinking, So I always say, well, it's not exercise, it's just start with small things, break it up. Because if you think about exercises, it's about the 1 hour in the gymnasium. But sometimes you really have to start really small and also ask about it, and then if they can perform 5 minutes of walking, I'm really happy. And if I show that and ask about it again, I mean, exercise could be so many things. And that's what we also have to make sure that our patients know, is that you can have a triumph with small things.
To add to the response you got there, the other thing is a safety factor. We tell everybody who's new in our boat, if you're too tired, just pull your paddle, and they can do that. So nobody is forced beyond their own safety level, and that's a really important safety factor in that context.
Hi, I'm Stephanie. I'm from Whippany. It's a city in the United States. So my question for patient and caregiver experts is, what is a phrase or a sentence that's been especially successful in explaining this level of extreme fatigue to somebody, whether physician, friend, other people, how unique it is?
Yes, so legitimately in my direction. So the question, if I could restate the question, how do you explain the type of fatigue that you get from ADT, which is mental and physical? And in fact, I think it goes across other cancers because chemo brain is a term that gets used so often, yet I have never seen a really good definitive explanation or definition of it. In my own talk, I gave you examples of actual cognitive impairment, for instance. Physical fitness can be measured in various ways in terms of grip strength, number of squats. There's a whole bunch of physical measurements for the physical fitness. For the mental fitness, the studies within prostate cancer have shown for ADT, there's been like 15 now at least, studies on cognitive impairment on ADT, and they don't come up with the same answer. In fact, some of them deny this, even cognitive impairment. But where it does show up in literature as the most dominant is in visual spatial processing. And it turns out women and men have traditionally, as stereotypes, shown differences in this area. And in fact, it was my own personal experience was, oh my God, I'm in my 50s, I'm in a huge parking lot, I can't find my car. And there was a moment then when I said, I can't be getting senile, this may be the drugs. And I actually, when I started, wanted to study it. So people, and I've seen, to say more about that, I've seen guys on ADT say, I don't have any of the effects. They're often in their 80s. I see guys at 50 years old who's a computer programmer who had to do all sorts of spatial relations for their job and feel like they have to quit because they can't deal with it. So that's not definitive. Not all the studies show that. But from a meta-analysis, the studies of studies, the most specific cognitive impairment that men on ADT experience appear to be in the visual motor spatial processing. And although this is not in the literature, my advice to these patients is clean up your desk, clean up your work area, decide where you're going to put your car keys, keep the area simple and organized. And that seems to have some effect, some positive effect.
Thank you. And a quick question to our healthcare provider experts. In terms of treatment selection, if there's a difference in fatigue or potential difference in fatigue profiles of treatment, to what extent might that influence or be accounted for within decision making?
For me, it's all about just get them moving. I mean, it's talking about ask what are they doing, what have they been doing 20 years ago, what do they like, and there isn't something they cannot do. I'm not afraid of that. I just need to find something that they can get, that they like, and then they start. I'm not even with people on chemo, even with people with lots of bone mets. That's not important for me. For me, it's important just find something that you like, and that could be a gymnasium, but then with a physical therapist. But for me, most of the time, it's really starting by walking and try to find something that you really like. I don't think there's any...
No, I don't. If I understand what you're saying, I think that there isn't an awful lot of choice in terms of a treatment that isn't going to cause fatigue because, A, it's quite personal and individual, and switching from one treatment to another, certainly in terms of ADT, isn't going to make much difference. In terms of chemotherapy, radiotherapy, etc., you don't have an alternative. So there isn't a lot of choice. The only choice that I'd probably say is probably between enzalutamide and abiraterone. Then you might, if somebody's already fatigued, you might be more prone to give them something with a steroid, which is going to increase their energy rather than enzalutamide, which is going to make it worse.
That's what I also ask. But before deciding one of the both, then I will ask them about their brain fog already, if they have it or not, or ask their loved ones if the patient already has brain fog, because that is important when choosing.
But it's difficult. But if there was an option, then absolutely yes, we take it into account. But there isn't a huge amount of wiggle room in terms of what we use.
Microphone 3, and this might need to be our last question.
Okay. I'll make it quick. I'm Sally, and I'm an oncology nurse, and I work in a hospital in Rotterdam. As an oncology nurse, follow-up is very important for me. That's what I like to believe. But I'm really keen to know from the patient's caregiver, what do you think about follow-up? Is it okay? Do you mind? Would you like me to phone you every 6 weeks, every 3 months? How are you doing? How's it going? Do I have some tips or advice from you? Am I allowed to nag you about exercise and movement? Is this what you want? I'm keen to know your opinion.
A follow-up in every way is essential. And there's umpteen studies that, for instance, have looked at where group gatherings of any sort are difficult to organize, and they want to look at, for instance, sexual recovery, and they're going to be called by a nurse every month or whatever. And the studies would show that there's a follow-up show improvement. So whether it's myself calling one of my buddies who didn't show up for a practice, or whether it's the oncology nurse calling the physician, everybody appreciates that. And it relates to this exercise stuff as well. We are a social species. The social interactions, the motivation in and of itself. So every follow-up you do, I mean, you may have of the patient who hangs up on you, I guess, that may happen, tell you I'm fine, stop calling me. But in general, every follow-up, but unfortunately they take a lot of time, whether you're not, whether it's myself as an individual supporting my own team as just a patient, or at the head of urology trying to consult with a patient. Every which way, that's part of the social dynamic that can encourage compliance. Keep on doing it.
Yes.
Follow-up by all means. Just avoid it having any connotation of sort of checking on you. That otherwise the patient is likely to feel that if they haven't measured up to what they perceive to be your expectations, that somehow they'll be to blame. I think you need to avoid that.
Thanks.
Go on, microphone 3.
Just a quick one. As a patient, I found COVID great because everything went online. So exercise classes, which I wouldn't have turned up to a gym for, were online. And the ones at Guy's are fantastic because they start with a half an hour introduction to fatigue or some other things, breathing, stress reducing levels and all that sort of thing. But going online, you don't feel as intimidated online as you do in a gym. That's all I'm going to say.
Thank you very much.
And it's a lot easier.
So I'd really like to thank our panel for their honest discussion of what it's like to live with prostate cancer and the complications of treatment. I'd like to thank Inga and Louise for some practical ideas or what you can do in order to improve it. I think my takeaway message is a little exercise. Prepare to exercise, plan it, just do a little thing and keep on doing it, and do it with friends, because this isn't just a physical thing, it's often a mental thing, and because we are social, that is very much what's important. There was a question, I think, if you've still got your phone out, if you can scan the thing. The question is, have we convinced you to do any more exercise? Now, can you start voting? Please say yes. It's not a loaded question at all.
Do you lie or do you lie big?
You see. So they lie big, it was all right. Thank you very much for attending, and that draws this session to an end.